Okay, hi Dr. Judge. I'm so sorry I couldn't line up a time with you. I've just been working double my work hours this week and trying to get the rest of our final stuff done. So my schedule has been very limited. In fact, I'm literally presenting this right after we just presented our research stuff. So this is my upper extremity portfolio. I'm super proud of it. I actually spent a lot of time throughout the semester working on it when I was at the Mayo Clinic with my mom. So it was really great. So I actually had opportunities to put a lot more information in here than what I thought. So my first part of it here is our case study point. So I had a 75-year-old female, just like you've seen for my presentation, with rheumatoid arthritis. She had an arthroplasty. So let me switch here. I just put in the first part a case summary, and then I have evaluation and clinical reasoning for rheumatoid arthritis, just kind of going over the principles, like a basic occupational profile, what that would look like on her, and then some standardized assessments I thought were good, and then I dive into more detail throughout the case study section. I did a mock initial OT eval thing on her of what I felt like we would find with client report. And like through the examination, like on here I have kind of like her pain scores, what her edema was at, just some of those basic things we're going to do at first. And then I put on here like she reported wanting to be more independent. She's struggling with like grooming and dressing with like buttons and a lot of fine motor stuff and cooking. Then I just have a little flow chart here going over what her findings were, some treatment priorities, what my intervention approach would be, and some of her outcomes because of her diagnosis. Of course, with rheumatoid arthritis, we know this is something that's going to have to continue. This isn't just a fix after an arthroplasty. She's going to continue to need treatment and continue to use home exercise programs. Just some precautions for her, and I broke it into weeks too, because some of it's arthroplasty and then some of it too is just having arthritis and knowing how to protect it. And I put on here too, I believe if you flip, because these are like multiple pages, like some joint protection principles as well for her, just not bearing too much weight, stuff like that. And then I have some long-term goals, like I said, because I put where the patient wanted to become more independent with daily tasks. I have one for dressing and grooming. I have a simple meal prep goal for her. And then the breaking us in the OT, I figured, which I'll get into a little bit later, the quick dash would be a very good assessment to perform on her. So I put in here within 12 weeks, the patient will improve the quick dash score by at least 15 points from the initial eval, indicating improved upper extremity function during daily activities. I also have doing the home exercise program, just some light household management. This includes like chores and meal prep, and then also because we would probably use a COPM on her as well. Within 12 weeks, the patient will improve her COPM performance score by at least 2 points in the areas of dressing and meal preparation, indicating increased participation and satisfaction with meaningful daily occupations. Those are all long-term. Her short-term, since we're 4 weeks out now with the arthroplasty, I have that she can don and doff her MCP extension orthosis, and then she can also increase active MCP flexion by 10 to 15 degrees with obviously following her precautions. I also have doing dressing skills, trying to do some medium-sized fasteners if she has like a button shirt or pants. And then I have in here reducing edema and some skills. My plan would also be with her to do like a soft tissue retrograde massage and teach her how to facilitate that on herself as well, or if she had somebody at home who could help her with that. I have my orthosis selection guide. My main guide that I picked was I have it right here. I'm sorry, I'm blinking now. It was the extension, MCP, no, I'm so sorry. The MCP extension orthosis. So, and it's right here. So I have that. I have the ulnar drift orthosis too. Even though she doesn't need it, it's kind of general, but just for someone with arthritis, I figured maybe. I also have in the back here a resting hand orthosis, because we don't know, her arthritis could get worse. And then dynamic MCP extension orthosis. And then I have a time chart to help me out, because that was kind of the point of my portfolio was. So this could be like a quick reference for me, or if I was struggling or was like, how long, or what would I do, or how would I facilitate that? So I have a lot of things like that in here. Just made her a quick little HEP, coding and billing, just some of the common codes that we would use. And then I just kind of gave myself a little chart here. I think therapeutic exercise for sure. Neuromuscular, we add therapeutic activities, like a lot of the basic ones we might see with arthritis. And then I just put examples like for therapeutic exercise, it's active range of motion, tendon glides, right? Grip strengthening, therapy, all that stuff. And then I have some ICD-10 codes down here as well. Just the one for like rheumatoid arthritis, ulnar deviation, stuff like that. Let me see. Okay, and then here's my SOAP note. I can send you a copy of that if you need that. Okay, oh no, I didn't put one of my cute things here. This is my assessment eval portion. So I have a little assessment guide. So basically, because again, I want this to help me in the future, I have my categories of pain, range of motion, strength, and there's more too, but I basically just put like, oh, if somebody's having pain, I can ask myself these questions. Is it limiting? Is it acute, chronic? All those things we need to be thinking as a therapist. And then by asking those questions, getting that information, I'm going to be able to narrow it down to, oh, maybe I need the pain body diagram to help them, the numeric pain rating scale. Or if it's range of motion, is the motion limited? Is joint mobility limited? And by then I know that I need to assess their range of motion, do like goniometer test, their end feel, all that, and strength. And so it gets into all of that. And then just another little quick reference here, just some stuff that I could use. And then I break it down into each one. I have the quick dash here, which this was great because I didn't know a lot of the upper extremity assessments that well. So I just have on here like again, quick reference, what it measures, who this is appropriate for, so I don't have to reference the manual every single time, and kind of like the scoring. And I even have like examples of scoring in the back here. It would just be a lot to pull out. Yeah. And then I have the little instruction part here oh, sorry, you can't see that, if I ever need it. And then I put grip this is so hard for me to say, dynametry, and then I have some of like the normal scoring skills in the back of it. Semmes-Weinstein monofilament to test, oh, I can't think of it right now, but like that nerve feeling, light touch, all that. And then I have a little guide here as well that I found online. Pinch strength testing, the 9-hole peg test is on this side. Goniometry, and then I have upper extremity evaluation checklist. I also thought too it'd be super useful to print off I guess I can put it like this, to print off the goniometry and manual muscle testing stuff as well. So that is always a quick reference if I don't know how to do it. And I actually love this because I have a couple complicated body kiddos where I've had to do the goniometer on them. And this has been great for me to see what's the norm, where their level is supposed to be. So I actually use that a ton even outside of this. And then I just figured, because we're getting into assessments, evals, having this on hand, the pain analog stuff would be great. Found this on Moodle, just a visual for patients, just so it's easier, and depends on like a patient's learning style too, right? Are they going to be able to exactly tell me, or can they actually show me? And then this is going to be very useful too. And then I have one of the like documentation things for it. This was on Moodle. I'm not sure if this was for evaluation or for a basic session. And intrinsics of the hand, just some different resources throughout these. And then, oh, I put that in the wrong spot. I think this is diagnoses. So I gotta switch that around. So this is now going into all of my diagnoses. I have thumb, CMC, osteoarthritis, or OA, and then same thing. Oh gosh, I need to push this back. I put the definition of what it was, the anatomy that's involved. So first CMC joint, trapezium, first metacarpal, stuff like that. Some common signs and symptoms. And I actually like this because if I ever have patients where they're complaining of it, I can reference this and be like, is this kind of what they're saying or no? And you know, it'd actually be great to have a lot more diagnoses. I just have 10 in here, but I think I could see where that would be very valuable. So yeah, common signs and symptoms: pain at the base of the thumb, decreased pinch strength, pain with gripping. I have some of their normal functional deficits, stuff like that. And then in the back of each of these sheets, I also put the evidence-based treatment protocol for them. So I was able to look up and see what the standard is. That way I know, just because I'm not super familiar with hands until this class and with me learning. So I just put on here like some of the goals for this type of diagnosis would be like decreasing pain, reducing their inflammation, and just trying to improve their comfort. And some interventions could be like joint protection, education, gentle active range of motion. Precautions would include force hold pinch, sustained grasping, heavy lifting. Criteria to progress would be like pain would decrease, obviously, which would be in the goals to improve functional use and better tolerance to ADLs. Then I have Dequiravians, tenosynovitis, and same thing. All of these are laid out the same way. So this is overuse condition involving inflammation and thickening of the tendon sheath around the abductor pollicis longus. And then I list the anatomy involved. Common signs and symptoms: pain over the radial side of the res, tenderness over the radial styloid, etc. Some of their deficits, same thing, going into some of the basic protocols for the evidence-based protocols. So just a lot of these are the same: decreasing pain, decreasing inflammation. Some are reducing edema, trying to improve their comfort. And then a lot of them for these diagnoses are just reducing the irritation so they can do their day-to-day task, wrapping it back into OT. And then interventions for them. Obviously, we want a forearm-based thumb spica for something like this. We probably are going to have to modify their activity depending on what process of this they're in. I have their precautions and then their criteria to progress. Next one was tennis elbow, lateral epicondylitis. I know a lot of people who has this actually. Same thing, anatomy involved, lateral elbow pain is some of the symptoms, tenderness over the lateral epicondyle. Some deficits would be like opening jars, stuff like that. Same thing, reduce pain, make them comfortable, protect the extensor tendon for this one. Cubital tunnel syndrome, common peripheral nerve compression syndrome of the upper extremity. It's when the ulnar nerve becomes compressed or irritated. Same thing. And then the protocol, I'm realizing you can't see that, I'm sorry. Flexor tendon repair is another one I chose. I chose these because when I was looking up the diagnoses, I wanted the most common ones that we would see in a hand therapy clinic if I was starting out, or if I end up doing my fieldwork, my level 2 fieldwork in one. So that's what I'm really trying to see, because this is so much information and it's so much to process and know, where I can foresee that if I'm put in a level 2 site, in my brain, this was how it was going to be more useful to me, where I could just see it. It was all laid out, organized, and say, okay, reminder, this is what it is, or hey, oh yeah, I do know this one, but I don't remember the precautions for it. So that's why I laid everything out this way. And then just because we like to wrap things back into evidence-based practice, that's why I also put just basic things on here. And I figured that would be grounds to where I could start treating for this specific kind of diagnosis. And then, obviously we get creative because we're OT. I put carpal tunnel syndrome on this. And then in these two, I also have the type of assessments you could use for them as well. And some ones that we wouldn't do as much as OTs, I think it's the Tinel test, I believe. So there's that in there. Then I put the degloving one because that was the one this semester that I literally had no clue existed, and I found the most interesting and the most gross. So same thing. Anatomy is the skin, subcutaneous tissue, fascia, common signs and symptoms. Obviously, we're going to be able to see that one. There's probably going to be horrible edema. We're going to have to do some sensory stuff with them as it's healing, when it's safe to do so. Trigger finger too. Put that one in here because this is super common. I don't know how much we see this in the clinic, unless it's super, I'm sorry, I don't know what word to use, super bad. But I know this is very common, and it's very common for people who have jobs with typing or using their hands a lot too. This is super, super common. And it can be super debilitating too, with our just normal daily tasks of typing, opening jars, opening a water bottle, opening Ziploc bags and packages. So same thing, evidence-based stuff. Then of course, rheumatoid arthritis, since I had my whole case study on it, all that's in there, and talking about the pain, stiffness, and things we can do. Evidence-based stuff. And then my last one was a distal radius fracture, because this is a very common fracture that happens, especially with falls as well, that we may see. Now, splints and orthotics. First, this is hard for me. This I think was one of the most challenging. It was fun because it was hands-on, and I actually loved this part for in-person time. But learning all the splints, and then what is good, what diagnosis is going those splints, that was hard. So this actually helped me, and this probably took me the longest time to put together, because this I just had to take a lot of time focusing on and learning all this stuff. So for me, I did a orthotic selection guide. So basically, just if we have a diagnosis of rheumatoid arthritis, a common orthosis is resting hand, right? MCP arthroplasty, we usually are going to have a forearm-based MCP extension orthosis. A carpal tunnel syndrome, we might have a wrist cock-up. Cubital tunnel syndrome, elbow extension orthosis. De Quervain's tenosynovitis, thumb spica. Trigger finger, we might have an MCP blocking orthosis. Thumb CMC osteoarthritis diagnosis may lead to a short opponent's CMC stabilization orthosis. Distal radial fracture, wrist cock-up. Lateral epicondylitis, a counterforce brace, which I haven't really seen that one before, so that was good when I was researching it. Flexor tendon repair, dorsal blocking orthosis, or hand degloving. We can do, a lot of them are customized, like you showed us on your presentation one week with the different hand injuries, or a resting hand, something like that. And then I just have a wearing schedule of when they more commonly would wear it, but obviously this depends too on where they are in their recovery, and then what the physician's protocol is for it, or the therapist protocol. And then just